صباح الخير عليكم جميعا. إن شاء الله نبتدي الجلسة الأولى في هذا المؤتمر، الجلسة العلمية الأولى. أنا طبعا أحب أوجه الشكر لدعوتي لحضور هذا المؤتمر، اللي أنا دايما بحرص على إن احنا نبقى موجودين مع بعض كلنا to share our scientific knowledge و experiences together. صباح الفل. احنا ان شاء الله عندنا جلسة على الدايلامز in breast cancer management، واحب ارحب بزملائي التشير بيرسونز معانا هنا، ما شاء الله قمم كلهم، يعني ان شاء الله نستفيد بخبراتهم كلها. الفيرست سبيكر معانا الدكتور اشرف الزيات، وهيتكلم على الهايلايتنج important aspects of patient management. دكتور أشرف الزيات، تفضل يا فندم.
بسم الله والحمد لله والصلاة والسلام على رسول الله صلى الله عليه وسلم. يعني أنا سعيد جدا بأن احنا النهاردة المؤتمر الثامن ووصلنا للي احنا فيه بفضل الله، ثم بفضل جهود الإدارة والأطباء، ثم بدعم كل الحضور والعلماء اللي معانا. أنا مش هتكلم علم خالص، لأن النهاردة في علماء أكبر مني وأقوى مني كتير جدا، فأنا قررت مش عاوز أتكلم علم، إنما عاوز أتكلم بخبرة 44 سنة جراح، 27 سنة منهم استشاري جراحة أورام ثدي في مختلف دول في العالم، فترة كبيرة في مصر. حبيت أهايلايت حاجات مهمة جدا لينا. أحيانا بنحتاج دايما نقف ونبص حوالينا ونعمل فاين تونينج كده، تظبيط بسيط. فانا حبيت اتكلم على الاوبزرفيشنز ديت، محدش ياخدها خالص بيرسونال، لا هي بيرسونال ضد انستيتيوت ولا بيرسونال اشخاص ولا سبيشالتيز. بس طبعا لازم اقول المقدمه ان our understanding of breast cancer and recent advances in management has led to a significant increase in early diagnosis, disease-free survival and overall survival. Over the last 10 years, breast diseases management has had a major leap forward in Egypt, زي ما كلنا اتكلمنا من شوية. Certainly, the National Cancer Institute of Cairo, together with Baheya Institute and many other universities like جامعة عين شمس, مع الدكتور رضا عبد التواب, we've been in the forefront of this leap. Dedicated breast units are now being established in almost every city and every hospital in Egypt. The structure of a breast unit, كلنا عارفين، مش go through it. Breast surgeon, plastic surgeon, if available, medical oncologist, radiation oncologist, radiologist, pathologist, psychologist, physiotherapist, breast care, nurse, and of course, guidelines and the coordinator to coordinate the work of this unit. We always need to stop, look around, audit ourselves, and fine-tune our practice, our structure, and our guidelines to the best. The international guidelines might have to be adapted to our circumstances in Egypt. Next few slides are not by any means pointing to any specific center or person or a specialty. Simply, from me, it is wishful thinking. We've had major advances, but we really need to fine-tune. Right. جزء كده من حديث حذيفة ابن اليمان: كان الناس يسألون رسول الله صلى الله عليه وسلم عن الخير وكنت أسأله عن الشر مخافة أن يدركني. The art of breaking bad, النقط اللي هتكلم فيها. The art of breaking bad news, continuity of care, radiology, pathologist, consistency and guidelines. The art of breaking bad news. Most cancer patients are fragile, at least at presentation. Please, fragile, handle with care. We should train every individual dealing with a potential cancer patient how to communicate with this patient. She's not a person. She's a potential cancer patient, not just the patient. Breast cancer affects a woman physically, psychologically, affects her husband, her mother, her children. لازم نبطل كلمات بنسمعها كتير بتتقال: انت ازاي سايبه نفسك كده؟ That's a very negative beginning. لو ما خدتيش العلاج هتموتي والمرض هيرجع تاني. That's very negative. معلش العيادة زحمة مش هنقدر نديكي وقت تاني. هو كده، ده شغلنا. عيطي براحتك، هتاخدي العلاج. اللجنة قالت كده، طب اشرحها لي. لا، هي اللجنة قالت كده. These are very serious issues. They are not science, but please, these are manners, and we have to concentrate on, please, we need to address. You need, when you say to a patient, your notes are positive, or should you say, only 2 are positive, but 14 are clear. It is the same meaning, but seriously different impact. Why did you neglect yourself to this stage? Or should we say, by coming now, you started the treatment. We will diagnose and treat you. Everything's treatable. We're saying the same thing with a totally different impact on the patient. We need always to start positive. Please. إذا دعت بقدرتك على ظلم الناس فتقدر فأعلم بقدرة الله عليك، بالذات لما بنكون بنشتغل في مؤسسات مجانية. بليز ناخد بالنا، المريض غلبان وجالك، بس هو أهم حاجة عندك، أنت بتشتغل علشانه. بليز bear with him. مالكش دعوة بحالته الغلبانة، المريض ده fragile. We know well-informed patient will accept the treatment no matter what it is. Even better cure rates. But we need to well inform them. Give them the time. The first support to the patient is her partner. He has to be there and encouraged to be there most of the time, because it's a very important support. We don't need دعم نفسي بعد كده if we start right. Continuity of care. That's a big issue. We are very busy. All big institutes in Egypt. Most cancer patients are fragile, as I said, at least at presentation. Is it right that patients meet a different doctor every visit? Is it right that the surgeon make a surgical decision in an MDTV not to have even seen this patient at all? Is it right that the doctor conveying the message to the patient not to have been at all present in the meeting? That causes a lot of confusion to the patient. These are fine tunes we need to address. I'm not saying we're not doing it. I'm just saying generally. Continuity of care is a very, very vital part in the patient care. The breast care nurse, they are vital. They are 50% of the power of any breast unit. In an ideal world, it is half the strength. Has to be present at the time of breaking bad news. خلينا دايما فاكرين, once you say to the patient you have cancer, everything is black. She's blacked out now. You keep talking, you're thinking she's understanding. She doesn't understand you. But the breast care can take her later and explain things thoroughly. Patients can feel embarrassed to talk to you about personal issues, but you will not feel that embarrassed with a breast care nurse, especially if you are a doctor. Multidisciplinary. We are as good as the radiology service and pathologist. They give us wrong diagnosis. We don't treat the patient properly. What do you expect from a radiologist? Nothing personal, not against any institute or against any person, especially not Dr. Rasha Kamal. Right. The role of a radiologist, screening, interpreting images, and advising further imaging modalities, estimating the nature of the lesion, estimating the size of the lesion, biopsying, assessment of the axilla, blah, blah, blah. Invaluable in breast unit, of course. But please, do we write a report to a patient or to the referring doctor? Please do describe the abnormality and suggest a diagnosis and recommend further imaging modalities. But please do not suggest treatment. This confuses the patient. You might say to the patient something, and the medical team sees something different, and that will confuse the patient. Please try not to take a core biopsy of a suspected lesion without a surgeon examining the patient. Unfortunately, it does happen. The patient comes to us, huge hematoma. The tumor could have been just 2 centimeters, but can you assess the size of a tumor in this patient? Please refer to a surgeon first before you take a core biopsy. The pathologist, they are great, but We need accurate diagnosis, grading of the tumor, accurate size in millimeters. Please, there's nothing called free margin. There are margins in millimeters. Lymphovascular invasion, we need to mention. Nodal metastasis has to be mentioned in millimeters. Not enough to say node metastasis, extracapsular invasion, multifocality and distance between lesions, presence or absence of DCIS, the receptor status. Advise us about pre-malignant diseases. But please, we don't like the word margins are free. We need sizes. HER2. We have a big issue here, especially in Egypt, about the HER2 reliability. I'm sure we will address that either today or in a different meeting. The medical oncology, our partners. Mr. Surgeon, we get letters. Mr. Surgeon, I want you to do breast conserving surgery. Mr. Surgeon, I want you to do mastectomy. Is it a medical decision or a surgical decision? We have advances in treatment options now that there are many options, not just one. A patient has to be part of the decision making. We take decisions in an MDT room, closed room, but we really have to sit with the patient and give her options. Nowadays, we don't have one option. We have many options, and we always have to select the one that suits the patient, even if it is the second option for me, but could be the first option for the patient. Please examine those receiving neoadjuvant therapy before each and every session. Unfortunately, we see patients coming, having had 2, 3, 4 sessions of chemotherapy. And when we examine, we discover that the tumor doubled and tripled. Please examine them before every session. Radiation oncologist, consistency, please. And I will leave it at that. Surgeons, I'm one of them. Medical oncologists have many lines of treatment. When one line fails, they come up with a second line. Wow, they are scientists. But you, Mr. Surgeon, you only have one chance. If it was not the optimum, you are a villain. You are the bad boy. So you have to be very careful. You don't have a second chance. Make sure you have seen the patient yourself more than one time. Make sure you counsel the patient well. Explain the options and possible outcomes and complications. Never let the plastic surgeon in you prevails. You are, after all, a cancer surgeon. If you don't know the end of an operation, don't start it. If you don't know how to handle a complication, don't perform the operation. It's always good to ask. Don't know how to do an operation does not mean it cannot be done. There is always one who can. See one, do one, teach one, pass the knowledge. Never forget to look after your family. We work very hard and suddenly we realize our children have grown up. They are married. We've never enjoyed them. We are tired now to enjoy anything. Please pay attention to your family. At last, guidelines. We always have to remember, guidelines have to be fine-tuned to every country, every institute, and the individual abilities. But guidelines are only guidelines and should never, ever be a substitute for good clinical judgment. This was simply observations plus wishful thinking. Thank you very much for putting up with me.
لو سمحتوا بس الاوديو فيجوال السكرين دي مش شغاله خالص. Okay. Thank you very much, Dr. Ashraf Zayat, for your very exciting presentation.
Dr. Ashraf, how to thank you. Very impressive presentation. الجايدلاين عندنا في البوك عندنا متاحة، إنما حضرتك to prescribe a job description of each team in MTT of great value. Personal thanks for your الطبطبة اللي محتاجاها المريضة وأسرتها، لأنه هو مش مرض فرد، ده مرض عيلة. Thank you so much, dearest Prof. Now, I have the honor and the pleasure to introduce an Egyptian international figure, Professor Nadia Mukhtar. Professor Nadia Mukhtar is the professor of pathology in NCI. Professor Nadia Mukhtar, on a personal level, I love her so much. She is a dedicated, updated pathologist, and I do promise إن احنا هنسمع محاضرة ما حصلتش update in cancer pathology of breast cancer 2026. Dr. Nadia, the floor is yours, sir. The title of dearest presentation, Dr. Nadia, HER2 testing and breast cancer after neoadjuvant anti-HER2.
صباح الخير جميعا. Thank you so much, chairpersons, and thank you, Dr. Lubna, for your kind introduction. I hope I'm up to it. شكرا لبهية وللدعوة الكريمة. أنا بحب دايما أتواجد معاكم في المؤتمرات، وإن شاء الله كل سنة. I see that the clock is moving, so I'd better start. I'm going to talk to you today about HER2 testing in breast cancer after anti-HER2 therapy. We all know the molecular subtypes of breast cancer, and as you see, 2 of them will contain HER2 positive disease. So are they the same? Can we lump them together? And the answer is definitely not. And we'll see how different they are. Well, here's the frequency of subtypes of breast cancer as mentioned by the Cancer Pathology Registry at NCI, but I believe it's worldwide, everywhere. So luminals are the predominant types, and triple negative is the least of them. However, we have this group of HER2 positive, whether they are HER2 positive or triple positive, and they constitute about 25%. Now, before I really start, I'd like to give this slide, which is the most important slide in my presentation, because if it is not followed precisely, then nothing of what I say will really mean much. We have quality control measures dedicated by the pre-analytic factors, namely from you. You should provide us with adequate material, properly fixed, neutral buffered formalin, 10%, and then the analytic factors, which include our choice of good antibodies, as well as always include controls. The post-analytic is the pathologist sitting at the microscope, and he has to be screening well. Not just a look, but give time to screen the whole thing. And also we have to follow the always changing guidelines and always follow the most recent ones with adaptation, of course. Now here is the immunohistochemical results of the HER2, which is the glycoprotein that we know with tyrosine kinase activity. It's either negative, score 0, or +1. If it has an incomplete membranous activity, or complete but thin, and this is the equivocal one, which we like to acknowledge with further tests like the SISH. And lastly, the it's frankly positive, which is a complete thick membranous reactivity. So, what about then the anti-HER2 therapy? Of course, this is your domain. But what I'm going to say is that there are these 3 classes, which include, of course, the first one, the monoclonal antibodies, most famously the trastuzumab. And this is against the external domain of the gene, which is the protein receptor on the cell membrane. The second is the tyrosine kinase inhibitors, or TKIs, and they block the HER2 signaling pathway from the nucleus to the surface receptor, most famously the lapatinib and others. The third class, which is the antibody-drug conjugates, most recent of them, and here you have the chemotherapy being adjunct to the receptor part. And every day we hear of new compounds giving even more better treatment results for the patients. However, not all patients react similarly when given anti-HER2 neoadjuvant therapy for so many reasons, multitude of reasons. It could be due to the therapy effect. And as we see, we have many classes of therapy protocols. Or it could be due to the host. The host has a unique molecular profile or a genetic profile, as well as the microenvironment, or most famously the comorbidities, especially the heart problems and so on. But let us now concentrate on tumor factors because of the time constraint. So what are the tumor factors affecting the anti-HER2 therapy? When you give the therapy, what do you expect from your patient? How would she react? First one is the percent or the degree of overexpression of HER2 protein on the cell membrane. Second, we'll talk about the estrogen receptor status. And then we will verge into the tumor heterogeneity, big subject, HER2 low status, and lastly, the primary versus metastasis. Now we start with the protein overexpression. Here are some cases of protein, positive protein expression cases, namely HER2 plus 3. And as you see that the, here, sorry. No, I'm going wrong. Something is wrong. I'm going. لا أنا عايزة أرجع. Yes, okay. So the protein overexpression. I have two cases here. One shows a complete pathologic response, the one on the right. The one on the left shows partial complete response. However, the cells are now being HER2 negative. And this sometimes they do and create a state of heterogeneity, as we shall see. Now, this is a paper that I saw on the net, and it's a very good paper managed by our colleague, Dr. Ahmed Racha, and it is published in the British Journal of Cancer, and it's studying the differential response of HER2 positive breast cancer to anti-HER2 therapy based on HER2 protein expression. And they came to a very clear conclusion, namely that the HER2 positive is overexpression, the protein, is the main predictor of response to anti-HER2 therapy. And this is actually a very, very strong conclusion, because as you see, it's like the نص كوباية فاضي ولا نص كوباية مليان. This is a very active, aggressive biologic disease, but it is still HER2 positive plus 3 is the best disease to have good response. Here is an example of HER2 plus 2, and the CISH was positive. And as you see here, the clusters of the gene being amplified in comparison to the chromosome 17. So this is a frank case of plus 2 plus amplification by CISH. So this patient will be given the therapy. But if you compare the HER2 plus to the HER2 plus 2 to the, compare the plus 3 to the plus 2 with CISH, these patients with HER2 plus 2 with amplification will show a significantly lower PCR rate. That's 22 versus 57. And also shorter survival regardless of the HER2 copy number. We're speaking now of the protein expression. And here, as you see this, my very crooked cartoon, the overexpression here, as you see, there is overcrowdedness of the receptors on the cell membrane. So much زحمة كبيرة قوي. And so they overcrowd themselves, and some of them may drop off with treatment, and some may be dropping away, or some even may be internalized into the cytoplasm of the cell, no more on the cell membrane much. And as this is one example of a case that you see, now here the cells are showing dense granular reactivity rather than the cell membrane, which tells a lot about the internalization of the receptor rather than being on the surface. And this is an example of a multivariate Cox regression model. Many of them are seen in the net. I've just chosen one. And you see here the variables, HER2 plus 3 versus 2 with amplification. And you see here that there's an independent significant predictor of pathologic complete response between these two diseases, being more towards the plus 3. And the figures here are quite convincing by statistical analysis. What is the effect then of estrogen receptor status? We talked now about the HER2 expression. Now we move to the effect of estrogen status. Triple positive cases, they are HER2 positive, but they are not the same as the HER2 plus 3 cases. Here we have an incomplete pathologic response. Many of the cells are still being positive and still being viable, because here the response is not as high as the plus 3. And the one conclusion is that the ER positivity significantly decreases the response to anti-HER2 therapy in IHC2 plus with amplification, not HER2 plus 3. And this is because the ER signaling pathways are more dominant in cases with lower HER2 positivity. Now we talk about the neoadjuvant anti-HER2 in HER2 low. And for the pathologists in the room, if you're not looking at your microscope with very high magnification, you will lose a lot of these cases that show only faint, incomplete, thin membranous reactivity that you really need to look carefully at. And in the literature, you see also many of these diagrams just showing the difference between the primary disease and the residual disease. How are they standing in terms of HER2 profile? And the HER2 negative cases would remain negative, but few of them would become HER2 plus 1. And vice versa, if some of the HER2 low with treatment, some of them may show HER2 negativity in the end of the treatment. So there's nothing exciting about this group, and the change is really minimal. Now we come to the problem or the subject of tumor heterogeneity, and we cannot declare that we understand it fully. By definition, HER2 intramural heterogeneity, or ITH, it's a coexistence of a subpopulation of tumor cells with different HER2 gene or protein expression. Some of the tumor cells are negative, some are positive. And it's not a rare occurrence. We see it a lot. Maybe we do not take care of it because it's not decisive of anything. That's what we think. But no, it is decisive of so many things. The frequency could go to up high to 30 or 40% of our cases. The quantitative is either +1 and +2 areas or +1 and +3 cases. So it is more, the heterogeneity is more with equivocal or low HER2 positivity. If the HER2 positivity is a bit lower, then we see more of heterogenic tumor distribution. The HER2 intratumoral heterogeneity in HER2 low in breast cancer is a bit of a barrier to the influence of HER2 assessment by the pathologist and the treatment by the oncologist. Here are some examples of the immunohistochemistry discordance. either we have areas that are positive and others are negative, or inhomogeneity in which some areas are +3 and other areas are +2. So the pattern of heterogeneity is either A, homogeneously negative, B, homogeneously positive, C and D are heterogeneous. Some tumors are positive, some tumors are negative. They can be either clustered positive or heterogenic mixed positivity. So this, and the patterns are, we call them clustered, mosaic, scattered, many patterns. The first slide is HER2 homogeneously positive, and the other one is homogeneously micro heterogeneous, and could be clustered in shape, mosaic in shape, or scattered. Again, another example of cases showing frank heterogeneity in their distribution, some in clusters, some in interstitial, and some in small groups, and some as individual cells. Again, this is an example of a case that shows clearly only few foci that are positive, the rest are negative. But for us, if we have more than 10% having positive, complete, thick membranous reactivity, that is considered positive. More complications, genetic versus non-genetic. If the genetic heterogeneity is including several genes, or whether it is in the same genome, and this is called non-homogenic heterogeneity. More and more of the complications, as I told you, it's a very complicated subject. Inter-tumor heterogeneity, when the tumor cells, the host cells, is intermingled with the tumor cells, or intra-tumor heterogeneity, in which the host cells are around the malignant cells and not in between. Whether this has an impact or any meaning or prognostic value, we're still to learn. So what are the clinical aspects? It's more frequent in ER positive tumors, 81 versus 19, that's significant. And as a significant association is seen between the HER2 heterogeneity and PCR. This is stratified by the estrogen receptor status, and this suggests that if further validation and routine heterogeneity is being mentioned by the pathologist in the report, this would give the oncologist a way to select patients for or escalation for therapeutic purposes. More clinical aspects, the genetic heterogeneity is always associated with poor prognostic profile and less responsive to anti-HER2 targeted therapy. So for the pathologist, again, when you are dealing with the guidelines, then please comment on the heterogeneity pattern and percent, or at least percent, because it is important. And also mention the low and the ultra low. And when we are comparing the quality of a biopsy versus specimen, we'll see that the biopsy is much more beneficial, but it has disadvantage of missing on tumor heterogeneity. Primary versus metastatic tumors, some of the tumors by natural history, whether they take a treatment or not, then they change from negative to positive or positive to negative with a total discordance rate of almost 14%, and that's quite a high figure. Yes, there are some true changes after the therapy, including the loss of PR after aromatase inhibitors, or of course the diminished HER2 expression after trastuzumab. It is not it's unknown whether these changes are transient or permanent, and the usefulness of this information to guide the patient management. So you see, we have a lot of problems that we have to deal with together, the pathologist, the oncologist, and everybody. Lastly, the points to consider is you must provide this with adequate biopsy material, properly fixed. Also, we have to manage the status of HER2 overexpression, compare it to the problem of gene amplification and how these are different in different cases. Estrogen receptor status is a very, very strong influential factor in this cascade of HER2, anti-HER2 therapy. And lastly, we have to really understand the problem of heterogeneity. Heterogeneity is not simple. It is a very complex subject that we are still trying to learn. And by each day and year, we learn a lot about tumor heterogeneity and the impact of such heterogeneity on patients' outcome. I thank you very much for your attention.
Thank you so much, dearest Prof. Very comprehensive presentation tackling a very important topic. Thank you so much.
Now I have the honor to introduce أستاذ الدكتورة هبة الظواهري الغنية جدا عن التعريف طبعا، لكن أنا ممكن أقول جملة واحدة بس، إنه بالرجوع لكلام الدكتورة أماني هلال ومحاضرة الدكتور الزيات، لو دورنا على موديل للدكتور الأونكولوجيست الشاطر والإنسان قوي قوي قوي، مش هنختلف إنها أكيد دكتورة هبة الظواهري. اتفضلي يا دكتورة هبة.
بسم الله الرحمن الرحيم ومساء الخير جميعا. شكرا جدا دكتورة عزة، كلام لا أستحقه. My dear panelist، لا بجد يعني خجلت جدا، وأتمنى لهذا المؤتمر النجاح، وأتمنى لمؤسسة بهية الدوام دائما. تعالي طب خليكي معايا ثانية كده، خليكي بس ثانية. My talk today will be about some changing in the management of the breast cancer, and I would like to see with you how this make us a variant landscape. It changes by time, and it changes. ممكن تفتحي لي الكمبيوتر ده؟ Why landscape of breast cancer? Okay, so I will talk about early breast cancer. The landscape, of course, is changeable year by year. More information when we use some agent in the metastatic setting, it come now to be used in the early and the adjuvant setting. While we know more and more about the genetic and background of breast cancer, it makes us more easy to treat the patient. All studies now are trying to improve the outcome of pre-operative setting. They are aiming to vanish or diminish a tumor bulk in the neoadjuvant setting, and maybe in the future, I am not happy to tell for the surgeon, the role of surgeon may be very minimal in breast cancer. So what's new in the last ESMO 2025? It was just a few days away. Shall we consider everything and every study a change in our practice, or shall we reproduce it in our clinical trial, or shall we choose what suits us? Okay. So talking about the luminal breast cancer, hormone positive, HER2 negative early breast cancer, we have some information from the last ESMO that we have to condense, and we have to add something in the endocrinal treatment in the adjuvant setting. This may be a very big practical changing and difficult to us, because now physicians have to improve what is called CDK4/6 inhibitor, maybe for 2 years if you use abemaciclib, or for 3 years if you use ribociclib. And I bring this from the very recent information have been projected in the ESMO that the standard of care for the luminal breast cancer in the adjuvant setting must reinforce it, and the patient will benefit addition of either ribociclib or abemaciclib. And they project the 2 main big studies. This is Natalia trial and the Monarchy trial. And I will not go very deep in the trial, but just to convince myself and convince you that this trial, Natalia trial, is 5 years outcome. They expose the patient to CDK4/6 inhibitor for 3 years, but the projection is still there. Projection is still there, and there is a difference. Maybe 4.5% of whole group after 5 years. So this is something encouraging to physicians to use such treatment. Okay. When we look to node positive and node negative, because in this Natalia trial, they include patients who have node negative, and this is very brave from them. Those patients considered as early breast cancer. When the question have been added in the very beginning of the trial, why should I combine many agents in such early breast cancer? But it shows that they benefit. Node negative benefit and node positive benefit after long standing of disease or follow-up. Here is overall survival. It is not significant, but it shows by year and year many separation of the curve that may be click in the future. So monarchy trial saying us, they collect a group of patients who are high risk, positive lymph node in axilla, tumor more than 5 centimeter, Ki-67 high, and they give the treatment only for 2 years. And after a median follow-up of 6.3 years, still there is many benefit for the patient to have a combination. This is in abemaciclib. If you wanted to compare the two things, the overall survival is definite on the right side of on the left side. There is a benefit of here in the abemaciclib, 86.8 versus 85 with a p-value significant. And the invasive disease survival is better while with addition of CDK4/6 inhibitor in both groups. This is transmitted to NCCN guidelines. If you follow with me, this is post-menopausal. We have pointer? Well, pointer? Okay, so in post-menopausal, first line indication, aromatase inhibitor 5 year, consider adjuvant abema and ribociclib. So it is now okay, and higher point. Okay, so the aromatase inhibitor here in the okay, shukra. In postmenopausal, the first aromatase inhibitor with abema and ribociclib is category 1. So for me, for example, this is make a burden on the institute like National Cancer Institute. Shall I will give all patients a combination of aromatase inhibitor 5 years and CDK4/6 inhibitor for 2 years? This will be very costly. So I have to select, and I have to make my mind, is this suitable to our country or not? And then if we move to premenopausal lady, same, tamoxifen, consider adjuvant abemaciclib or for some eligible patient. Again and again, it is become a standard of care in treatment of those patients. And the question now come like this combination for all patients, the answer for me is no. It is only for those with any lymph node involvement, tumor size 5 centimeter, grade 3, Ki-67 more and above 20%. If the patient subjected to genomic, we have to see a high recurrent score. And if patient have all these factors, will be preferred to them to give CDK4/6 inhibitor. But take care, inside this trial, there is something very important, that adjuvant CDK4/6 inhibitor studies in high-risk patients who already receive adjuvant and the neoadjuvant chemotherapy. So we cannot emphasize that this benefit is for CDK in addition or not. Again, there is a limited data to those patients who didn't receive any chemotherapy. Please take care. Nowadays, in the luminal breast cancer, there is addition of BRCA mutation information. If you have a BRCA positive patient, so you have a burden and distress as well to give the patient anti-PARP inhibitor. So now I am in a hot soup or I am in dilemma. Her adjuvant will include what? Will include abemaciclib and the PARP inhibitor. The sequence up till now is not sure which the first and which is the second, and still we are not sure where is the sequence of this adjuvant treatment. Going to HER2 in the early breast carcinoma, we have two important studies that have been projected in the last ESMO. With these two studies make like a striking or a bomb, زي قنبلتين تم تفجيرهم في الإزمو بيغيروا how we treat the HER2 patient in the adjuvant and the neoadjuvant. The question come now, is it practical to do the same? Is it practice changing? Do we need more mature data? And these two is Destiny Breast 5 and Destiny Breast 11. Destiny Breast 11 have been projected in the main session by a major name, Nadia Harbek, which she give us that the anti-drug conjugate can replace the trastuzumab, pertuzumab in the neoadjuvant setting. And they give us a positive study that by doing this in a comparison of 927 patients, PCR 67 versus 56 in those who have the classic and the ordinary way of neoadjuvant. Is this good for hormone receptor positive? Yes, it click. And the patient who have TDXD treatment upfront have a hormone receptor positive, have a PCR 61 compared to 52, while in the negative 83 versus 67, both of them are statistically significant. And they project everywhere that trastuzumab deruxtecan is moving to be a curative setting in early HER2 positive breast carcinoma. But there is some caveat. Okay, so there is some caveat in this study. Although it is positive study in favor of TDXD in the neoadjuvant, but we have many concerns. Number of patients, they collect the people from around 400 centers, so maybe some violation or instability or non-homogeneous data. Percent of PCR in both groups are very low if compared to other studies like Catherine trial. Okay, so what about Destiny 05? Destiny 05, they would like to kick out the TDM, which we given to patients who have a residual disease after neoadjuvant, and replace it by TDXD. And they do this trial, including 1,600 patients. The invasive disease-free survival for patients who have TDXD, 92 comparison with 83, statistically significant. And the bone metastasis-free interval also significant. So they recommend patients who have anti-HER treatment in the neoadjuvant subjected to surgery and have a residual disease, we may offer them anti-drug conjugate TDXD. Okay. On the other side of the spectrum, they do much and expensive drug. Can we go chemotherapy free? Can this anti-HER expensive drug omit chemotherapy? So we have a very nice trial that it is we have, as mentioned by دكتور أشرف الزيات، يا ريت نفولو عيانينا كل شوية، يمكن نغير العلاج. هو نفس الكونسبت. So they do PET adapted strategy to see early responder and avoid them chemotherapy. هيدوا 2 cycle of the neoadjuvant anti-HER2 treatment without chemotherapy, and they will do PET-CT. If there is much response, they will continue the treatment without chemotherapy and then subjected to surgery. And this have been projected in the Lancet 2023, a very important paper talking about 3-year interval, 3-year invasive disease-free survival with chemotherapy de-escalating using PET-based pathological complete response adapted strategy in HER2-positive early breast cancer, FAIR-GAIN trial. The name of the trial is FAIR-GAIN, and you don't bother yourself by all this figure. You can just see if the patient is ER, any stage from stage 1. Group B, they have pertuzumab Herceptin. If the patient is hormone positive, they give her in the neoadjuvant endocrinal treatment just for 2 cycles, and then they subjected to PET. Look with me for the gray boxes. If response, they complete the same treatment for 6 months and subjected to surgery. If CR, they complete it for 10 cycles. If not responding, they go for chemotherapy, and they compare these two group or these 2 line with the classic line that we all use it. And they look for PCR after PET respond, and they look not now or after 1 year, 3 years invasive disease. So what we find in this trial, the result shows that maybe 1/3 of the patient can have a pathological CR without chemotherapy. And those patients who didn't receive chemotherapy have a very good disease-free survival after 3 years, 95%. The update in the last ESMO that those group of patients still have a very good response, 98%, and this may encourage me to select some patient in the clinic not to have chemotherapy. I will assure them a good survival after going for just anti-HER2 treatment, but my role here is to follow them early by PET-CT. And this is invasive disease-free survival, and this is the conclusion. They are talking about de-escalation or omission of chemotherapy in this group of patients, and this is very nice. In a very few words about triple-negative breast carcinoma, triple-negative breast cancer, nothing very new or very exciting in the last ESMO. They are still talking about giving pembrolizumab, as have been mentioned in the keynote trial 522, is good option in the neoadjuvant, and still they are asking if we will continue in the adjuvant or not. And if the patient have a BRCA mutation, we can add in those triple-negative patients in the adjuvant setting PARP inhibitor. Here is the updated curve that we give the drug for 1 year, but after 5 years, it is still separated, and so some benefit for patients who have pembrolizumab in their neoadjuvant. Okay, and this make us a very big question. What about toxicity? What about to de-escalate chemotherapy in the very beginning of, as long as we have a good overall survival and separation in the pembrol arm? Why not to omit chemotherapy? And why not to escalate in non-responder? What about the residual tumor and how we deal with it? The last slide or the last information coming from the last ESMO is in India, they project a very important study about low-dose pembrolizumab in addition in the neoadjuvant. They call this planet trial. And they are very smart and very intelligent. They use 1/6 of the dose in the neoadjuvant, and they have a very similar result. So the map or roadmap of the early triple negative may be a little bit complicated. In the neoadjuvant, we need to have taxane platinum, of course, and pembrolizumab. And then after surgery, if no pathological complete remission, we can go to capecitabine, but with 1 year pembrolizumab. And if the patient have a German-like BRCA mutation, we add olaparib. If patient enter in PCR, no further therapy, or, and this is very hot issue now, complete pembro for 1 year. So landscape is changeable. You have to think of a combination of CDK4/6 inhibitor in adjuvant. In HER2, I am not very convinced because the data is very new and لسه طالعه من الفرن, and I will not take it now, but I will be patient. We may kick out the trastuzumab, hertuzumab, and give anti-drug conjugate in the neoadjuvant. In triple negative, pembro in the neoadjuvant, olaparib in the adjuvant, Allahu a'lam pembro in the adjuvant or not. And please, we have to reproduce the low dose study in our country. Thank you.
شكرا جزيلا دكتورة هبة على المحاضرة الجميلة دي. وهنخلي الأسئلة في الآخر يا جماعة إن شاء الله. دلوقتي دكتورة رشا كمال هتقول لنا محاضرة عن breast imaging selection matching modality to clinical need. الدكتورة رشا طبعا أستاذ أشعة في جامعة القاهرة في القصر العيني، والدكتورة رشا هي من أوائل الناس اللي ابتدوا البريست ايميجينج في القصر العيني بعد الدكتور أشرف بيه سليم طبعا، وأول ناس اللي ابتدوا البريست ايميجينج في بهية، وهي ليها دور كبير جدا في التعليم التيتشنج والتدريب والبحث العلمي، وكلنا بنشوفها في المؤتمرات وبتسري العلم وبتسري التعليم. فتفضلي دكتورة.
شكرا جدا يا دكتور. بسم الله الرحمن الرحيم. Matching breast imaging modality to clinical needs is defined as the process of choosing the most appropriate imaging technique based on the clinical presentation, patient characteristics, and diagnostic goals in order to achieve accurate, efficient, and cost-effective care. And so in this lecture, we will try to shed light on how we can select the right modality for the right person and in the right time. My lecture will be divided into 3 parts, and in the first part, I'm going to give a briefing about how the different breast imaging modalities function in order to be able to use them in our daily practice. Most breast imaging modalities either depend on giving us an enhanced morphology assessment, and these include the mammography, the tomosynthesis, and the ultrasound, or they depend on giving us some functional information about the tumor cells, and these include the PET mammography. And we have other modalities which can combine both, like the MRI and the contrast mammography. I think everybody is acquainted with the mammography and the ultrasound, so I'll start by giving a briefing about how tomosynthesis works. The technique of tomosynthesis is simply like the mammogram, where the breast is placed here in between the compression plate and the digital detector. But what's different from the mammogram is that the X-ray tube moves in an arc across the breast, giving a series of low-dose images that are acquired at different angles with a total dose similar to a single-view breast exam. So the end result, seeing the breast from different directions, we have a 3D image of the breast that can be viewed in cuts of few millimeter up to 1 centimeter exactly like what we do in CT. We go slice by slice in the breast. And this means that using a tomosynthesis, we can overcome the problems of tissue overlap in mammography-dense breast. And it is mainly a screening tool, not a diagnostic one, because using tomosynthesis, we can detect more cancers and we can decrease the recall rate in the same time. The next modality is the PET mammography. And the principle behind PET mammography is that as the tumor cells proliferate and grow, specific metabolic pathways are activated. And one of these pathways is the anaerobic metabolism, where the glucose is uptaken by the cell by the glucose transfer enzyme. Inside the cell, it is subjected to the hexokinase, which changes it into glucose 6-phosphate, which undergoes glycolysis in order to provide the tumor cells with energy. If we have 18F labeled FDG, it goes through the same pathway until we reach the glycolysis. This doesn't occur, and this means that the FDG will be trapped inside the cell, and this gives us time, adequate time for imaging the radiotracer while still inside the breast. In PET mammography, the images are displayed as 12-slice tomographic views, exactly like tomosynthesis. We go slice by slice in the breast. We can view them as static images or as cinefilm, and we can view them also as grayscale or color-coded scale. The way we interpret assessment, PEM, is we do both a qualitative and a quantitative assessment. The qualitative assessment is exactly like what we do in MRI and contrast mammography, and the quantitative assessment is similar to what we do in PET-CT, where we measure the PUV instead of the SUV, and we measure the lesion to background activity. We have to remember that PEM is a secondary and not a primary diagnostic tool, and it is only used when contrast mammography and MRI fail. The last group is the MRI and the contrast mammography. Both modalities are used in the assessment of breast lesions, where both modalities also have features in common. In both modalities, we inject contrast agent to highlight areas of concern within the breast. But the way they do so is different. In MRI, we take a pair of pre and post-contrast images, and then we get the subtracted images in which everything is cancelled apart from the lesion which has uptaken the contrast. In contrast mammography, it's different. We first inject the contrast, and then we take a pair of low energy image and high energy image, which is not a diagnostic image, but we use it in order to get the recombined image in which everything is cancelled apart also of the lesion which has shown contrast uptake. Both modalities also have features which are different from each other's. If we compare both, contrast mammography is less time consuming, better tolerated, with a relatively lower cost, and it is easier to interpret, and we can still assess microcalcifications in the low energy image. But we have to admit that up till now, MRI is still, in spite of all these advances, it's still the top-notch modality because it allows better lesion detection and characterization. Now we move to the second session. In contrast mammography and MRI are considered diagnostic tools, and they are mainly used in local staging, but they also have some screening applications. Now we'll move to the second session in which we will know how these modalities are applied in solving some clinical scenarios. And we'll start by the detection and screening. This is a screening mammogram of a 46-year-old female. She had a tiny lesion seen in the MLO view in the left breast. We felt it looked like an intramammary lymph node. The artificial intelligence gave it an abnormality score, which was not very high, but we had to recall the female. We did an ultrasound examination, which revealed an underlying tiny irregular hypoechoic mass lesion, which was biopsied and turned out to be invasive duct grade 3. And I think it should be recorded as a success story for any screening program if we can detect high-grade tumors at such a small size. The next case is a screening mammogram of a 43-year-old female. Again, she had a tiny lesion in the left breast. On the mammogram, it looked benign, but this time the AI gave it a high abnormality score, and we recalled the lady not because only of the AI, but because the tomosynthesis showed that this lesion was irregular, had an irregular outline. We performed the ultrasound. It was not good looking on the ultrasound, and we took a biopsy. It was an invasive duct carcinoma grade 2. This is another screening mammogram of a moderate risk 51-year-old female. She had no masses or calcifications on her mammogram, but the person who performed the ultrasound was not satisfied with the heterogeneous dense breast parenchyma, and he told her, in your next year, do an MRI in addition to the mammogram. On MRI, we saw a hypointense lesion on the T2 and the STIR, and this lesion showed contrast uptake, and it was actually an invasive lobular carcinoma. We went back to the mammogram. Have we missed the lesion on the mammogram? And the answer was yes, because if we had compared similar areas in both breasts, we would have been able to identify this very subtle focal asymmetry in the right breast. And this was the ultrasound examination of the same. So in general, in screening, the female population is classified into an average risk, moderate risk, and high risk individuals. For the average and the moderate risk individuals, we perform mammography starting the age of 40, and it might be complemented with an ultrasound examination. For the high risk and the average risk, we do the same, but at the younger age, and we should include MRI in the screening of high risk individuals. If you look at contrast mammography, it has the potential to be to replace both mammography and MRI, but up till now we have no enough studies validating it's safe using it in high-risk individuals, and it is used upon recall of screened individuals. If we have tomosynthesis, then we should include at least one view tomosynthesis in the screening of the patient. The next scenario is the nipple discharge. This is a 50-year-old. She presented with bilateral spontaneous milky nipple discharge. She had a heterogeneous dense breast. Nothing was seen on mammogram, while on her ultrasound there were markedly dilated mammary ducts with retained secretions. If we looked at her history, she had discharge, which was bilateral and milky. We had to assess for the prolactin, and she had hyperprolactinemia, so we thought of a central cause. She performed an MRI examination of the brain, and there was a pituitary adenoma. Another case, she's a 53-year-old, presented with right bleeding per nipple. She had this retroareolar mass, and see how beautiful it was illustrated on the ultrasound. We see the duct clearly with an intraductal papillary growth. It's only ultrasound which will show us this picture. And it was biopsied, and this was an intraduct papilloma. Another case with a uniorificial bleeding per nipple. She had multiple nodules in the left breast. Her clinician ordered for contrast mammography, which added nothing because we still see these three nodules and nothing was added. Comparing this to what we see in ultrasound, we see the dilated duct and the actual intraductal lesions projecting within the duct. This is the last case. She's a 46-year-old female with history of left bloody nipple discharge for 1 year. She had a heterogeneous dense breast parenchyma. Her ultrasound was simply a mess with many dilated ducts, areas of non-mass lesions, and we thought that the MRI would solve the problem. Actually, it became worse because everything in both breasts was enhancing. A biopsy from the right breast revealed lobular carcinoma in situ and multiple papillomas, and from the left breast it was ADH, and they recommended for another larger biopsy. But when we came to which site to decide where to biopsy, it was a dilemma. And in some of these cases, we resort to the PET mammography, and we select the area which has taken the highest FDG uptake, and we biopsy this area. And actually, this was invasive cribriform carcinoma and DCIS. And again, another reminder, it's not a primary diagnostic modality, it's a problem solver modality when other modalities fail. So nipple discharge is a common clinical complaint. It might be due to a central etiology or a peripheral etiology. The central etiology is suspected whenever we have bilateral milky spontaneous discharge. We have to check for the prolactin level. If we have peripheral nipple discharge, it might be either physiologic or pathologic. The typical physiologic is bilateral, multi-orificial on squeezing the breast, and it is milky, green, or yellow, and it occurs in cases of duct ectasia and mammary adenosis. While the pathologic is typically unilateral, uniorificial, spontaneous, bloody, and it usually occurs with intraductal papillomas and some malignant breast lesions. So when we have a case of nipple discharge, we should examine the nipple, decide whether this is physiologic or pathologic. If physiologic, no specific imaging is needed other than screening mammography if applicable. If pathologic, then we do a sonomammography, and only if negative should we resort to other imaging modalities. The next station is with the inflammatory breast lesions. This is a 44-year-old. She's a diabetic female with tender left breast. She had left breast which was denser than the right breast. On the ultrasound, there were fluid-filled dilated ducts with periductal inflammatory changes. She was told that she has to take a short course of antibiotics and come for a follow-up. And the follow-up ultrasound was performed, and there was nearly total resolution of the inflammatory process. This is another 53-year-old female with the right breast, which looked very bad on the ultrasound, and even the lymph nodes looked worse than the mass itself. We did a mammogram, and the mammogram also showed a focal asymmetry with peripheral speculations. The MRI confirmed that this is definitely a malignant lesion, but when we biopsied the lesion, 2 times the biopsy came telling us that there are no malignant cells. After 2 weeks, I asked them to repeat the MRI. We even did a PET mammography because we did not believe the pathology, and the PET was also a typical appearance of a malignant lesion with high uptake. We repeated the examination 2 weeks later, and the picture was totally different. Now we see multiple intercommunicating abscess cavities. They were confirmed by a second look ultrasound, and the patient was followed up, and gradually she improved until complete resolution. Inflammatory breast lesions, this is another 3 different cases. There is a global asymmetry with enhancement pattern of the left breast, which is typical for malignancy, although the first case was a periductal mastitis, the second was granulomatous mastitis, and the third was malignancy, and all of them looked the same on a contrast mammography. Inflammatory breast disorders actually encompass a wide variety of breast lesions with different management protocols, starting from the simple mastitis, which is treated with antibiotics and hot fomentations, up to the inflammatory carcinoma. And to reach an accurate diagnosis often entails repeated unnecessary examinations and unnecessary biopsies. Patients presenting with inflammatory breast symptoms experience severe breast pain, and that's why most of them, not like whenever we have a breast mass, they present in the acute stage. And at that stage, ultrasound is the modality of choice, and we resort to mammography in selected cases. MRI is only reserved for resistant mastitis to exclude underlying malignancy, so please do not recommend MRI or contrast mammography in the acute stage of mastitis. Now we move to the 4th station, and this is the breast pain. This is a 24-year-old female patient presenting with bilateral diffuse cyclic mastalgia. We meet this scenario a lot in our work, and usually we do an ultrasound, and the ultrasound states that this is a normal study, and in these cases, no further imaging is needed. This is another 45-year-old female patient presenting with bilateral mastalgia. She had multiple obscured lesions on the mammogram. Most of them turned out to be cysts, but unfortunately, in between these cysts, there was an irregular solid mass and a pathological axillary lymph node. The mass was here all the time, but it was missed because of the dense breast parenchyma. This is an example of unnecessary imaging. She was a 35-year-old female with cyclic mastalgia. Her mammogram showed subtle asymmetry in the left breast, and we did an ultrasound. There was simply focal fibroglandular tissue condensation, and her axillary lymph nodes were good looking. We diagnosed it as focal adenotic parenchyma, but the clinician was not satisfied, and he asked for a contrast mammography, and it's normal to see some degree of enhancement whenever we have focal fibroglandular condensation. And he asked for a biopsy, and the biopsy results again came with focal adenosis. Mastalgia is also a common symptom experienced by up to 80% of women at some point in their life. It might be non-cyclic or cyclic, and it might be focal or diffuse. For non-cyclic focal mastalgia, further imaging is appropriate to exclude underlying pathology. But for cyclic diffuse mastitis, further imaging other than regular screening is inappropriate. We move to the last one, and that is the palpable breast mass. This is a 45-year-old female with multiple palpable left breast mass lesions. If you look at the mammogram, we see two mass lesions. The first one shows typical features of a malignant mass, and actually this was an invasive duct carcinoma. The second lesion shows typical features of a benign mass, and it was a fibroadenoma. Sometimes we need an ultrasound to confirm our findings, and actually these were the pathological axillary nodes. This was the speculated mass with microcalcification, and this was the good-looking fibroadenoma. And no further imaging is needed other than sonomammography. This is another 50-year-old female. She had a black breast lump and she had renal impairment. She had a mass lesion, an evident malignant mass lesion in the left breast associated with skin thickening and with pathological axillary lymph nodes. The problem of the left breast was solved, but there was a problem in the right breast that we saw multiple small nodules and we did not know which to biopsy, which is benign or which is malignant. This was the ultrasound examination, and again, the left breast was a problem because some of these nodules were good looking and others had irregular or speculated outline. And she had renal impairment. We cannot do MRI, we cannot do contrast mammography, so we did PET mammography, and PET mammography showed that the left lesion was not a single lesion, it was a multifocal disease, and the right breast, there was only one of these nodules which showed contrast radiotracer uptake, and we biopsied it, and it was an invasive duct carcinoma grade 2, and the left breast lesion was an invasive duct carcinoma grade 3. Palpable breast mass is one of the most frequently encountered complaints, and it is one of the commonest presenting features of breast carcinoma. Whenever we have a palpable mass, we look at the age of the patient, above 40 or below 40. Above 40, we start with a mammogram, and it is usually complemented with an ultrasound, and MRI and contrast mammography are reserved for local staging, and a biopsy, if we suspect malignancy, should be performed. In young individuals, we start with an ultrasound examination. We might or might not need a mammogram or the MRI and a biopsy, further biopsy. And usually no additional imaging is needed other than sonomammography. To wrap things together, if we have an asymptomatic patient, she should be only sent to regular screening mammography. If we have tomosynthesis, add it to one view in the tomosynthesis, because it decreases detection and it increases detection and decreases recall rate. MRI should be used in screening high-risk individuals, and contrast mammography up till now is used upon the diagnostic workup of recalled patients. If we have a symptomatic patient, we either start with ultrasound or mammography according to her age, and we might need the other modality, and in most of the cases, this is enough. Ultrasound is the best modality whenever we suspect intraductal lesions or mastitis, and contrast mammography and MRI are reserved for local staging and lesion extension. And thank you.
شكرا دكتور رشا. نايس برزنتيشن، وان شاء الله كلنا استفدنا من المحاضره القيمه دي. وبعد كده طبعا انا يعني اقدم طبعا اخويا وزميل النيابه والمدرس المساعد والسكن في معهد الاورام القديم والبروف شريف نجيب، طبعا هيكلمنا على الاكسيلاري سيرجري. ممكن تتعمل ممكن ما تتعملش الآن. طبعا احنا جيل يعني حصلنا وشفنا الراديكال ماستكتومي، ويكاد يكون كان الاكستندد راديكال ماستكتومي، ويمكن كان هيعمل رسالة في الدكتوراه انه نعمل سامبلينج للانترنال ميموري ليمف نودز، وقعدنا في الموضوع ده فترة. بعدين كنا صغيرين ما نعرفش نقول للأساتذة لا وما ينفعش، وفي الآخر ما غيرنا الموضوع. فالآن الدكتور شريف بيه هيتكلم على الأكسيلاري سيرجري. هل هتظل قائمة أو لا؟ خلاص ممكن تبقى شيء من الهيستوري تفضل يا بروف. شكرا.
أشكرك يا دكتور منصور، وأشكر الأورجنايزنج كوميتي وبالذات الأستاذ دكتور ماهر حسن لهذه الدعوة الكريمة. I will be presenting the most recent advances in axillary surgery, and if axillary surgery is soon to be obsolete and completely neglected in breast cancer treatment. We know that for over 100 years during the 20th century, and most of it, axillary dissection was an integral and essential part of treatment of breast cancer, especially with mastectomy, and even during the era of breast conserving surgery, all axillary nodes had to be removed as a gold standard. But then it proved to have a lot of side effects, and little could be done to avoid the ill effects of axillary dissection, as you can see here. And then in 1971, what I like to call a big bang, which is a practice changer, occurred. And this was a publication that nobody really noticed, and that was published in 1977. It was a randomized controlled trial called the NSABP B4, which was undertaken by Bernard Fisher, which contained 3 groups of patients with breast cancer. The first group was treated with radical mastectomy with complete axillary dissection. The second group was treated with axillary irradiation. And the third group was treated with simple mastectomy and only axillary observation. And it was found that in the 3 groups, there was no real difference in treatment failure or in survival. So this should have been a practice changer, but unfortunately, this study was underestimated and neglected, and I think it was too daring for the 70s. And as you can see here, until the 1990s, still publications insisted on complete axillary dissection, claiming that it decreased axillary recurrence and was more accurate in axillary staging. Until Armando Giuliano had the audacity to stop axillary dissection, and he proposed sentinel lymph node biopsy in the late 90s. And the technique of sentinel node biopsy is pictured here. And it was validated by so many trials, which all proved that sentinel node biopsy had an identification rate of more than 90%, false negative rate of less than 10%. And when compared to axillary dissection, it showed the same or almost the same disease-free survival, overall survival, and axillary recurrence rate. And then another step towards de-escalating axillary surgery occurred with the American College of Surgeons Z11 trial, which was also led by Armando Giuliano, where patients with 1 or 2 positive sentinel nodes could be treated without axillary dissection on condition that their primary tumor would be less than 5 centimeters, which means T2 maximum, presented by clinically negative axilla. They would have breast conservation surgery and receive whole breast irradiation, and wouldn't have extracapsular extension in their sentinel nodes. These patients were allowed to avoid axillary dissection if they had a maximum of 2 positive sentinel nodes. And this technique was validated about 7 years later by Giuliano, and avoiding axillary dissection proved to have the same overall and disease-free survival as continuing axillary dissection after positive sentinel nodes. One further step towards avoiding axillary dissection was the CENOMAC trial, which was published last year in New England Journal of Medicine, which expanded the indications for the Z11 trial. It still insisted on a maximum of 2 positive sentinel nodes, but it included patients with T3 tumors, patients who would undergo mastectomy, and patients who would have extracapsular extension in their sentinel nodes. And in these patients, it was allowed to avoid completion of axillary dissection if the number of positive sentinel nodes did not exceed 2 nodes. Of course, these patients had to receive postoperative whole node irradiation. And then came another further step towards avoiding axillary dissection in patients with positive sentinel nodes. They took up the number of positive sentinel nodes into 3 or more in this study that was published last year. And it was apparently found that in clinical practice, about half of patients with 3 or more sentinel nodes were omitted from completion of axillary lymph node dissection in clinical practice. But this was only done mainly in old, frail patients with low-risk tumors. As a matter of fact, we cannot recommend this as a standard of care, but it should be considered for individual cases. And then came another step towards de-escalation of axillary surgery, which was the AMAROS trial, which tried to replace completion of axillary lymph node dissection in patients with positive sentinel nodes to be replaced by axillary irradiation. And it was found that irradiation gave the same overall and disease-free survival as completing axillary lymph node dissection, and it even gave half the incidence of lymphedema when irradiation was given when compared to axillary lymph node dissection. Since we're talking about de-escalation of axillary surgery, we cannot avoid presenting the TAXIS trial, which is tailored axillary surgery. It is a kind of axillary lymph node picking, like the one that we use in thyroid cancer, where the sentinel nodes are removed together with any palpable suspicious node and any clipped lymph node, with preservation of the rest of the axilla. And the rationale of this technique is to reduce the nodal tumor burden to allow radiation to control any microscopic residual in the axilla. And the preliminary results show non-inferiority between TAXIS, which is tailored axillary surgery, and complete axillary lymph node dissection. Nevertheless, we still need further evaluation of the results. This is a really interesting topic. Can we do sentinel node biopsy in patients with clinically node positive axilla or radiologically node positive axilla? Actually, the rationale for this is that the axillary ultrasound is examiner dependent and it doesn't have a very high predictive value. And the advantage of doing sentinel nodes in these patients is that almost half of them will show 2 or less positive sentinel nodes, which will qualify them for avoiding axillary lymph node dissection according to the Z11 criteria. Nevertheless, this is still under study. These are practice-changing studies, the SOUND trial and the INSEMA trial, which propose replacing sentinel node biopsy and axillary surgery altogether by ultrasound. This is the design of the SOUND trial in patients with clinically negative axilla and negative ultrasound. They randomized patients to either axillary surgery or just follow-up. And they found that there was no inferiority between avoiding axillary surgery and doing sentinel node biopsy if ultrasonography was negative. As you can see, in both groups, the same distant disease-free and overall disease-free survival and overall survival were the same. This is the design of the INSEMA trial, which is almost similar to the SOUND trial. The only difference is that they included T2 patients in their groups, and they also avoided axillary surgery completely if ultrasound was negative, and they found that in clinically node-negative patients, whether T1 or T2, omitting surgical axillary staging and omitting axillary surgery altogether was non-inferior to axillary surgery in the form of sentinel node biopsy if axillary ultrasound was negative. Nevertheless, we surgeons do have concerns regarding omitting axillary surgery completely. We still do not know if this can be applicable to large tumors, because in the SOUND trial, only T1 tumors were included. In the INSEMA trial, only 20% of the patients had T2 tumors. We do not know if this is feasible for high-grade tumors, since the INSEMA trial contained only 4% of grade 3 tumors, and 88% of the study population in the INSEMA trial were postmenopausal luminal patients. Also, the rates of axillary irradiation were not reported in both of these trials. We are also concerned about undertreatment if we omit axillary surgery, because in patients with 1 to 3 positive lymph nodes, regional nodal irradiation, according to NCCN guidelines, and CDK4/6, according to Monarchy trial, improve survival. So these patients will be missed if we omit sentinel lymph node biopsy. We also fear overtreatment, because we know that whole breast irradiation can be avoided in postmenopausal luminal A patients if they prove to be histologically negative nodes. But these patients will not be detected, so they will all receive whole breast irradiation. Also, partial breast irradiation will not be feasible if we do not prove that the patients are histologically negative in the axilla. So we do have concerns about complete omission of axillary surgery until now. What about axillary surgery in the neoadjuvant setting? We have become a little more daring and more courageous in patients as regard axillary staging after neoadjuvant chemotherapy. There are 3 randomized control trials that are trying to prove that post-neoadjuvant irradiation of the axilla is non-inferior to axillary lymph node dissection in patients with positive sentinel nodes. These trials are still ongoing, and namely the TAXIS trial, the Alliance A011202, and the Adarnat study. They are similar to the Amaros study, but in the post-neoadjuvant setting. And another further step towards de-escalating axillary surgery post-neoadjuvant chemotherapy is omitting axillary surgery completely in patients who present with pathological complete response in the breast, especially if they were clinically negative before neoadjuvant chemotherapy, because it was found that the incidence of positive sentinel nodes in these patients was almost 0%, especially in patients that are HER2 positive and triple negative breast cancer who show excellent response to neoadjuvant treatment. So there are 2 ongoing studies nowadays that are trying to evaluate avoiding axillary surgery in patients who present pathological, radiological complete response after neoadjuvant chemotherapy, especially in triple negative and HER2 positive patients, namely the EU Breast 1 trial and the A6 trial. So to summarize, in the early 90s, sentinel node biopsy advised omitting axillary lymph node dissection in patients with 0 positive axillary nodes. In 2011, the Z11 trial expanded the indications for omitting axillary lymph node dissection to include patients with 2 or less positive sentinel nodes. In 2024, some studies started contemplating omitting axillary lymph node dissection in patients with 3 or more positive sentinel nodes. And in 2012, the Amaros trial established the efficiency of axillary irradiation in replacing axillary lymph node dissection in patients with positive sentinel nodes. In the coming years, there might be a lot of research aiming at replacing axillary surgery by axillary ultrasound in selected low-risk patients with clinically node-negative axilla. So to wrap up, the 21st century has witnessed a lot of de-escalation for axillary surgery in breast cancer, but will axillary ultrasound, axillary radiotherapy, neoadjuvant chemotherapy soon make axillary surgery obsolete? This is the question nowadays. And I thank you very much for your attention.
Thank you, Professor Sharif, for this elegant and comprehensive presentation as usual. I think we'll move to another next session of next speaker. We will continue to discuss the other methods of de-escalation in the treatment of breast cancer. It's my pleasure and my honor to introduce my colleague and my brother and السند اللي هنستند عليه لما بحتاج أي حاجة. Professor Dr. Ahmed Amin. Ahmed is Associate Professor of Radiation Oncology at the NCI, and he's the head of the Radiation Oncology at the Baheya Center. His presentation will be about the de-escalation of post-operative radiotherapy in breast cancer management.
شكرا جزيلا دكتور محمد. Good morning, chairpersons. Good morning, everybody. It's a great pleasure to be presenting at Baheya Conference as usual. Since I'm the last speaker in this session, so I will try to take just a few minutes of your time, especially that we're proceeding with an important session, which is the lunch. So I will try not to, just to spend just around 7 to 8 minutes in this presentation. Actually, this topic it's a very important topic in our practice. So today I'm going to talk about the de-escalation of the post-operative radiotherapy in breast cancer management. In the past, almost 60% of the breast cancer patients were indicated for adjuvant radiotherapy. This was in the mastectomy era. But after the introduction of conservative breast surgery, and now we are doing much more conservative breast surgery, the incidence of the patients who are receiving adjuvant radiotherapy raised to 95%. So almost most of our patients, they receive adjuvant radiotherapy. And the role of radiotherapy is very well established by the breast cancer trialist group. The breast cancer is so important for the local control and to decrease the deaths from breast cancer. And this role was really established with a huge meta-analysis, so we can't deny the importance of the adjuvant radiotherapy. And we can see that with the introduction of new techniques and proper radiation therapy, we can see that we can now control the local control up till 1% of our patients are subjected to local recurrence. And even for the advanced breast cancer, we're having positive lymph nodes. The breast cancer role was also, the radiotherapy role is also very established, and it has its important impact on the local regional control and the deaths from breast cancer. But I just mentioned the importance, but we can't also deny the toxicity of the radiotherapy. Radiotherapy, it has its drawbacks. Sometimes we see some major complications. Thankfully, it's just with a few of our patients, but we can see edema, peeling of the skin reaction, fibrosis, telangiectasia. And beside that, we have also some significant impact on the reconstruction. That's why I'm always having this discussion with the surgeon whenever they're doing some piece of art reconstruction. They're always like scared if I'm going to destroy their piece of art. And actually, that's a fact, because when we're having a good construction without radiotherapy, Rate of complication, it's almost about 50%, but after radiotherapy, without radiotherapy, it's just only 20. So yes, we have our impact on the reconstruction. This means that whenever radiotherapy can be omitted, but of course it has to be a safe omission, not just omission to avoid side effects. So whenever there is if there is a possibility of omission, we have to address this. And today I'm talking about this, the possibility of omitting radiotherapy, whether to omit the whole course of radiotherapy or to omit the volume or to de-escalate the volume of radiotherapy or the number of fractions. This is what we're going to go through in the last upcoming few slides. Now we're having a very important data during the last few years regarding the totally omitting radiotherapy for the patient who are having low risk for local recurrence. We have the Luminal A trial published like 2 years ago. And this was, let's say, a practice-changing trial because they introduced to us important data that we can omit radiotherapy safely for some selected patients who have low risk for recurrence. And these include patients with T1N0, grade 1 to 2, luminal A breast cancer, and of course, they have to be above 55 years old. We have another important data from the Precision trial. Precision trial, they even recruited even younger patients starting from 50 years old. And they also had the same result that for selected patients with T1N0, luminal cancer, HER2 negative, we can omit radiotherapy safely, but actually these data are still not that mature. The follow-up was 26 months, just 2 years. So we are even waiting for further data to make sure that omitting radiotherapy for older patients is a safe practice. Another trial, the Prospect trial. Prospect trial, it's based on the imaging. If we are having proving that using MRI that breast cancer is unifocal and there is low risk for recurrence, we can also omit radiotherapy for these patients. Another type of omitting radiotherapy are for the patient with N1 disease. When we started our practice, maybe like 20, 30 years ago, sometimes we were omitting radiotherapy for the patient with N1, like 1 to 3 lymph nodes. We were omitting radiotherapy for these patients until we have some criticism on this practice. So even in the NCCN guidelines, we started to consider radiotherapy for such patients. But recently, we are having multiple ongoing trials that are revisiting this area. They're revisiting for those patients who are doing a mastectomy with just 1 or 2 lymph nodes, upfront surgery with 1 or 2 lymph nodes. We might consider omitting radiotherapy. So we are revisiting this area, and the prelim results for these trials are encouraging that it might be a safe practice for such patients. What about de-escalation after neoadjuvant chemotherapy? We have also a very recent and important publication, the B51 trial in the ESMO, like 1 year ago. They introduced a very interesting data of the P51 trial after the neoadjuvant chemotherapy. They recruited patients T from 1 to 3 and with N1 disease, but this N1 should be proved by FNAC. And for this patient who is going to achieve pathological CR, they were randomizing, even omitting radiotherapy or prescribing radiotherapy. And if the surgery is mastectomy, they were omitting radiotherapy at all. And if it's conservative, they were giving radiotherapy to the breast only without lymph nodes. And of course, we're having lots of surgeons and all of us are oncologists. We know the meaning of omitting radiotherapy to the nodes and its effect on the toxicity, especially for the lymphedema. And the data of this, the primary endpoint was the recurrence-free interval. And you can see from the curve, I don't have to comment on the curve. The 2 lines are identical. The secondary endpoints, the same way, you're getting the same curves, the local regional recurrence-free interval, the distant recurrent-free interval, the disease-free survival, and the overall survival, or the 2 groups were matching. And from this data, we are starting to have some solid evidence that omitting radiotherapy after neoadjuvant chemotherapy is going to be introduced. More or less, most of the guidelines, they didn't consider this yet because we are waiting for even longer follow-up, but mostly this is what's going to be introduced in our guidelines in the future. What about de-escalation of the tumor volume? it's encouraged now. We have two types of practice for the patients, low risk patients who are not, when we're not treating the lymph node. We might, for some selected patient, consider a partial irradiation of the breast, not the whole breast irradiation. And the data we're having more data now, even in the guidelines. It's a category 1 for some patients now. So de-escalation of the volume to minimize the volume of the treatment in order to minimize the side effects should be also encouraged in our practice. And regarding the side effects, in general, the radiotherapy side effects is not that much, but with the partial breast irradiation, it's much and much lower. So it's encouraged for the patients who are eligible for that. Another type of de-escalation is the de-escalation of the treatment course. In the past, we were giving our patients our course. It was like over 25 fractions, and sometimes it's over 30 fractions when we're prescribing a boost. But now, during the last few years, we have evidence on the hypofractionation, and we have, of course, a lot of landmark trials. I'm sure you're familiar with them. And after this, the most recent trials, which was published after 2020, starting with the COVID, the data were published. The FAST trial, where we're giving just 1 fraction every week, and then the fast forward trial, we're giving just 5 fractions over 1 week, and that's it. So this is a de-escalation of the course, and we can see that even this practice is minimizing the toxicity. So with the fractions over 1 week, we can lower the acute toxicity from 13.6 to 5.8%. De-escalation of the tumor bed for patients with conservative breast surgery after the whole breast irradiation. Other radiation oncologists, for our patients, it's always introduced in our practice to offer them extra dose or like extra few fraction to the tumor bed for better local control. And we're having data that not all patients will benefit from this. We have to select our patients so that for elder patients for above 51 years, the benefit from the boost is minimal and it's not significant. So part of our de-escalation, we should only prescribe boost for the patient who will benefit from this boost. And we have the RTOG 1055 trial, which is not omitting the boost, but it's like prescribing the boost concomitantly with the radiation, so that if we're prescribing the radiation over 3 weeks, there is no need to add extra 1 week of a boost. We can introduce the boost during the 3 weeks of radiation, so that we will not prolong the course of the radiotherapy. The last thing is I mentioned now that in our practice, we can prescribe radiotherapy over just 1 week. So what about the boost? There is multiple ongoing trials that the boost can also be introduced concomitantly with this 1 week, so that there is no need to prescribe radiation over 1 week and then another week of boost. We can just introduce the whole radiotherapy course over 1 week, including the boost. There is multiple trials that is investigating this. One of the most important trial in the UK by Anna Kirby, they just launched their trial maybe a few months ago. And mostly because we are doing this in our practice for some selected patients, I believe that even for the patients who are going to deserve boost, we're going to deliver all our treatment over 1 week without any prolongation. And this is going to be one of the interesting de-escalation in our practice. So just to summarize, whole breast irradiation remains a standard for most early breast cancer patients. De-escalation in dose and boost and volume, like partial breast irradiation, can be considered for low-risk group. Omission of radiotherapy can be proposed in older age patients. Response to neoadjuvant chemotherapy has proved to have its influence on radiotherapy decision. And there is an ongoing research aiming for proper selection of the patients who can benefit from radiotherapy based on their submolecular classification. Thank you very much.
Thank you very much, Dr. Ahmed. And now we open for discussion. I think the best way is that to start with first and then the second speakers. Any questions for Dr. Ashraf Zayat? Yes. Can we have a mic here?
Thank you, Dr. Thank you, Dr. Ashraf, for the inspiring talk and you sharing with us the challenge openly when you had this. It's always this innovative project that has big challenges. This is very inspiring, especially the young generation, and احنا to be more determined في our vision ان احنا enhance breast health care. Regarding the talk, أنا very agree with you in one point and disagree for another point. Agree with about the communication. Even I have a whole talk about communication, and أنا كرadiologist, breast imaging radiologist, how my communication can lead to malpractice and أو maldiagnosis. يعني كان حتى يعني مش واخدين بالهم إن ممكن communication to lead to misdiagnose. The other point disagree شوية اللي هي إن breast imaging radiologist كfront line كهم اللي برضه بيدايجنوز يعني determine the by rads which case to be biopsied or not. What I saw في البراكتس في كندا where I had my training يعني ان كانت البريست سنترز هم الفرونت لاين سبيشالي في السكرينينج مش الدايجنوستيك بس السكرينينج لو انا determined ان هي البيشنت need to be biopsied they finish everything before they and get the pathology and do the correlation then refer it to the surgery clinic. يعني ده كان شايفاه ان هو يعني fasting السيرفيس make السيرفيس fast وان هي يعني بتدي ان هو clinical radiologist مش هي النقطة بس يمكن ان هو لازم to be a specialized breast imaging radiologist so you are as a surgeon يعني ان انت تبقى واثق في الديسيجن بتاع الراديولوجيست ان هو he will take the او she will take the biopsy not to refer first to the surgeon. This is what I saw في البراكتس في الويست وكنت شايفة ان هو حل حاجات كتير. انا طبعا يعني لما كنت برضو first لما كنت رايحة كنت يعني as we trained here ان احنا we don't speak to the patient get back the patient to the surgeon وكده بس when I took this confidence برا و get back تاني يعني ده فرق كتير جدا حتى في البراكتس بتاع السيرجنز اللي معايا وكده ان هم شايفين ان الديسيجنز خلاص بتبقى اسهل اسرع ويعني ليد على طول لفاست سيرفيس واكيوريت سيرفيس فيعني ده اللي كنت عايزه اقولها.
شكر جدا طبعا وانا I was actually inviting الناس ترد عليا في ديت. احنا في عصر الارتفيشال انتليجنس فكل كلمه حضرتك هتكتبيها في الريبورت المريض هيروح يبتدي يحطها ويشوف الارتفيشال انتليجنس هيقول له ايه. حضرتك ممكن تقولي له a diagnosis والجراح زي بنسمع for wire guided excision بعدين تجي لنا المريضه احنا شايفين ابروتش ثاني بس هي قرت الريبورت بتاعك وحطيته في الارتفيشال انتليجنس وسمعته اما بنيجي نتكلم معاها هي اوريدي كونفيوزد خلاص بتقول لك بس الدكتور الراديولوجي قال لنا كذا كذا كذا. فدي حاجه مهمه عشان كده بقول هو احنا بنكتب الريبورت للمريضه و addressing اللانجوج بتاعتنا للمريضه ولا are we addressing a clinician who is going to read this report. الحاجه الثانيه my practice for 28 years in the UK whenever we are screening there was always a doctor, a surgeon available. When they are going to take a biopsy, please call this surgeon. He will examine, he will record clinically the size of this lesion. So when they have the hematoma after the core biopsy, then we don't get confused in our surgical plan. فإحنا مش مختلفين أنا بس بوظف او باخد بالنا من الارتفيشال انتليجنس اللي المريضه النهارده بتجيلك جايه بتتكلم حضرتك قلت لها حاجه والارتفيشال انتليجنس قال لها حاجه والدكتور اللي هيقابلها هيقول لها حاجه فبتبقى شويه ديفيكالت. عشان كده قلنا بليز ادريس الدكتور بالريبورت بتاعك suggest diagnosis but please don't suggest treatment option and please الهيماتوما really confuse us. فخليها براكتس بين كندا وبين انجلاند ان احنا whenever we are going to biopsy زي ما بيعملوا في بهية اول ما بيشوفوا abnormality they call a surgeon or they send the patient down to the surgeon in level 1 who will examine and then she will go up. again for the biopsy.
Thank you very much. Professor Sharif Naguib, comment.
Thank you very much. This is mainly a comment to Dr. Ashraf بيه طبعا ودكتورة رشا هانم ودكتور أحمد أمين. We as surgeons always are supposed to mark the tumor bed after breast conservation with clips so that the booster dose of radiotherapy can be delivered to the tumor bed. The problem is not all surgeons do it, and most of the radiodiagnosis colleagues are surprised to find these clips, and most of the time they tell the patient الجراح بتاعك نسي حاجات جوه، ده حاطط دبابيس، ده نسي دبابيس جوه. فتيجي المريضه تتخانق مع الجراح، ايه اللي انت نسيته جوه ده يا دكتور؟ I need two things if this honorable crowd can allow me to. I need that radiodiagnostic people tell the patient that your surgeon has left clips and has marked the tumor bed with clips, and this is a good surgeon, to encourage the surgeon to do it. And I need radiodiagnosis people to know that this is not something that the surgeon has forgotten, but this is a duty that he has to do in every breast conserving surgery. We're facing a problem with this issue.
Okay, may I comment here on two issues? Number one is the communication between the radiologist and the oncologist or surgeon. Usually in European and American, the report is written not to the patient but to the treating physician, whoever is. But the lady or the patient has to communicate with the radiologist in the form of did you find anything, for example, or whatever else. And usually we answer that if there is a cancer, radiologist finds a cancer. I think the best way to tell the patient is that we look as it's being a relatively suspicious area, but we will communicate with the treating physician and see what would be the next step. This is number one. And we give it. The second issue is very important, is that the decision is usually made through an MDT, and this is very important, not only in breast, but also in many other tumors elsewhere. And the MDT discussion should have, as you mentioned, Dr. Ashraf, is that they should be the ones who are responsible for treating the patient, and they should examine the patient and see all what's about in the findings. Number three, in answering Professor Sharif, I'm really astonished what he just mentioned, is that I think that the breast imaging should be left only for those who are specialized in breast radiology, not just any people. I'm sure no one in breast imaging radiology should say these words, because we all know what you just mentioned. And it's ridiculous that someone would say that the surgeon forgot or missed whatever else. The important thing is that in most of the countries, they put a clip after we take the biopsy. But this, as we know, is very expensive here. The clip here costs about 6,000 Egyptian pounds just to get the clip. So it's very expensive. I know that there are some maneuvers to deal with the expenses that we use other form of clips, but I'm talking about the professional clip. So that's my comment. Dr. Ashraf, I think you want to add something.
حضرتك يا دكتور أشرف أوجزت بالضبط ولخصت. أنا بس هعقب على إحنا بنقول للراديولوجيست make a diagnosis, suggest a diagnosis, but please convey this message to the patient, but do not suggest.
Sure.
Unfortunately, we get at least
This
in the
is
private
too bad.
practice.
I mean, I cannot say in my report you have to do a conservative breast surgery or you have to do a neoadjuvant. I mean, of course, it goes without saying. Thank you. Any further questions to Dr. Ashraf? Yes, the mic is here, please. Mic.
Thank you, Dr. Ashraf, for your nice presentation. My question is that we get always a sort of dilemma between the communication of the treating physician oncology and the patient. If you get a late stage patient, we two options. Either tell patient directly, your case is so and so and so. This is like Western communication. Or please live in peace and enjoy life. What is your suggestion? Tell the patient the truth that you have so and so, or let him, okay, because I get one of the famous oncologists to one of my relatives. He is so nice. Tell me, let the patient enjoy his life. Don't tell him anything. Let him play, eat, and everything. He has 3 or 4 months to live. So better to get here these 3 months in a joyful life, not in a memory of so and so and so. Okay?
Well,
You get my point?
Yeah, of course.
Okay, thank you.
Not telling the patient her diagnosis is a crime unless she is demented. But if she is aware, if the patient is aware, not telling her the diagnosis is a crime unless she is demented. But I'll tell you the art of breaking bad news. In the UK, I used to monitor my registrars as how they break the bad news. I'll just give a little example here. It's a funny example. One day I told the registrar, break the bad news and escalate. And he started to say to the patient, you know, when I saw you, I looked bad. When I saw the X-ray, it was very bad. He's escalating, adding very every time. And when you took a biopsy, it is very, very bad. He understood escalating in a horrible way. But there's a different way. When you talk to the patient, you might say the same thing, but in a different. Forget about very, very badly. You can say to the patient, well, we don't like it. Let us see what it is. And she will accept it. Never use the word, أنت عندك سرطان. Why don't you say, عندك ورم غير حميد? It is the same meaning, yet less impact on the patient.
Thank you very much. I think we now shift to Professor Nadia Mukhtar. Any questions for her?
If you allow me, and I would like to comment. I congratulate Professor دكتورة نادية الأستاذ المعلم دائما. This is يعني the best way to give us the platform how to think in any clinical trial in the future. يعني احنا دلوقتي في المعهد شغالين على heterogeneity in the HER2. لما أنا أسمع المحاضرة بتاعتها وأشوف إزاي الHER2 فعلا basically on the pathology البروتين will not respond to the anti HER2. يعني بجد شكرا يا دكتورة نادية، وبرافو انك بتفتحي مواضيع جديدة، وما شفتش او يعني من القلائل الباثولوجيست اللي كان ماستر the basic science, the drug science and how we apply it. شكرا يا دكتور.
Thank you very much, Dr. Heba. And now any question for you now, Dr. Heba Zawahri? Any questions? Yes, sir.
دكتور هبة دايما بتتحفينا بالمحاضرات الجميلة يعني. I am very pleased to what I've listened to with regard the escalation chemotherapy with HER2 positive, particularly early breast cancer. And I used to ask in the MDT, Dr. Amani, Dr. Iman, وكل الناس, why do we give chemotherapy for such patient with an early breast cancer who is HER2? And they always say, because it increases the incidence of complete pathological response. do you think are we in the new era of completely omitting chemotherapy? I mean, will it be the standard of practice tomorrow and the day after? Or are we still sticking with the old guidelines where we give chemotherapy for HER2 positive early breast cancer to make the pathological complete response more evident?
الأستاذ الدكتور حمدي المراكبي أشكر حضرتك على التعقيب والكومنت. Yes, my answer is yes. We are in the era of de-escalation of chemotherapy and going more to targeted therapy. This will be a very good in some selected patient, like very young patient who deserve to continue their maternal life. We can choose some patient who will expose to anti-HER2 treatment. ما بين القوسين هو غالي ويمكن anti drug conjugate زي الانهيرتو which is غالي قوي, but we can assure the patient the same 95 و 92 و 82 pathological CR. هتمشي بعد كده بمينتننس اللي هو الانتي هيرتو. سؤال حضرتك valid جدا. وكمان في الالderly patient above 70 nowadays some guidelines recommendation in the St. Gallen don't do radiotherapy. Okay, طب okay, don't do chemo as well in this elderly patient. كمان المثال الثاني triple positive post menopausal lady عندهم 2 clones that drive the growth of the tumor, the estrogen receptor and HER2. Why we add chemotherapy? We can give endocrine treatment with anti-HER2. احنا فعلا في الايرا بتاعه الدي اسكاليشن. هو بس الماي كونسيرن يعني دي اللي حد ممكن يسالني فيها ما تفرحيش قوي لان هو الانتي هير ما زال غالي, ولكن لا for the benefit of the patient. يعني في كتير بيجوا يسالوك, مش عايزه اطول, ارجوكي اديني دواء ما يوقعش الشعر مثلا, وشيز يونج وشي will survive وcomplete her journey. طب اوكي, we can do anti-HER2 بس if indicated.
Thank you very much. Now we should, okay, Mike.
My question to Professor Dr. Nadia Mukhtar. Thank you for your kind and concise presentation of HER2. Dilemma in HER2 that we get at the first diagnosis of true cut biopsy. We get the receptor, for example, positive or negative, and HER2 is negative. How can I overcome the heterogeneity of the tumor? Because maybe later in mastectomy it become positive. So what is your recommendation to overcome this dilemma?
It's not in our hands, it's in the hands of the radiologist. You have to have the guidelines for a complete, satisfactory core biopsy. 5 cores, each core 1 or 1.5 centimeters. Less than that, they call it inadequate. So I'm sure that if we have 5 cores, long ones, from different areas as much as possible, Dr. Ashraf, from different areas of the tumor, 99% we will have a good picture of the whole tumor.
Thank you, Professor Nadia. Yes, this is true. And these are the guidelines that we set up for all during the المبادرة الرئاسية. And biopsy should have 4 to 6 cores, at least from 1.5 to 2 centimeter long each core, and taken from different parts of the tumor, as you just mentioned. Yes, this is the guidelines of the radiologists, and we, for those, for the radiologists that are among us, please, I'm sure that these guidelines are mostly followed by most of the radiologists. Thank you very much. And now we shift to Professor Rasha Kamal for the time. for the time.
سؤال أخير.
معلش for the time. Professor, I'm sorry. Professor Rasha Kamal, any questions for her? Professor Ikram.
شكرا دكتورة رشا. في الحقيقة بس موضوع البام، حضرتك الحالة اللي عرضتيها اللي هي كان عنده في الليفت بريست ماس، وبعدين بظهر شوية ساتلايتس جنبيها، وبعدين في الرايت بريست كان في نوديولة تانية أو كذا نوديولة، واحدة منهم بقت بوزيتيف. فحضرتك يعني دلوقتي الحاجات اللي بيم أظهرها ما ظهرتش قبل كده، أو ما كناش متأكدين إن هي
كنا شايفينها بالسونار، وكان يعني كان في مالتيبل نوديولز، اغلبهم شكلهم سيركمسكرايب، بس واحده منهم كانت ما بقيناش متاكدين هل كل النوديولز دي حاجات فعلا ولا لا. هو احنا بنستخدمه استخدام ليميتد خالص البام، يعني ممكن في الشهر مثلا نحتاجه مرتين 3، لان السلكشن في الحالات فيه يعني من ضمنها بايوبسي منين دي. الناس اللي عندها 100 حاجه جوه البريست ساعات الواحد ما بيبقاش عارف يتارجت اني اريا، وساعات بنقول نخش في الموست سسبيشس بالالترا ساوند، وبيبقوا يعني دي تخيب يا تصيب يعني. فهو بيوجهنا اني الليجنز اللي واخده ابتيك جامد، فبنخش نتارجت الليجنز دي وناخد منها البايوبسي. هو المفروض ان احنا نركب كمان بام جايدد بايوبسي، بس لغايه دلوقتي ما عندناش.
طب حضرتك ده البام هل هيغير التريتمنت، يعني البلان اوف تريتمنت كبيشنت هياخد كيموثيرابي الاول، هياخد نيو ادجيفنت؟
لا يعني مثلا في الحاله دي لو انا ما كنتش شايفاهم ان كلهم مش واخدين خالص وكنت بايوبسي واحده، يعني ما عملتش البام وعملت بايوبسي من واحده وطلعت بوزيتيف، كان هيبقى قرار في اللجنه انها تعمل ماستر، لان انا هقول الباقي، مش بقول همشي ورا كل نوديول واخد منها بايوبسي، بس كان هيبقى قرار ان عندها مالتيبل نوديولز وسكاتت في البريست، وخدنا من واحده منهم طلعت بوزيتيف، فكانت هتعمل ماستكتومي. دي احنا عملنا لها كونزرفيشن وبنتابعها واحنا مطمنين ان ما فيهاش حاجه.
Thank you very much. Okay, one more. I'm sure there are many of you want to ask more questions, but because of the limited time, we'll stick to 2 questions for each speaker.
I have
mind, please.
I have comment and one question. In multidisciplinary, multi-center tumor, biomarker biology of the tumor difference from sometimes from region to other, not like multifocal disease. For example, one nodule may be triple negative, another may be positive. This difference in management in general. My question is: there is a new modality of screening by thermal imaging. It is true, or it is sensitive. But you have a Sweden group visit our clinic, and is very sensitive in less than 40 years patient, very sensitive. And it's take FD clearance, not approved. FD clearance. I know, but this
Thank you. Okay, thank you. Now we shift to Professor Sharif Naguib. Any question for Dr. Sharif Naguib? For Dr. Sharif Naguib? Okay. بعد إذن حضرتك معلش الوقت. Any questions? Okay, I have one question for Professor Sharif. There are some surgeons. حاضر يا فندم حاضر. Some surgeons sometimes ask for biopsying axillary lymph nodes, putting clip in axillary lymph nodes, and later on wire localization for axillary nodes. From your opinion, expert opinion, when do you need such procedures to be performed?
Marking the axillary lymph node with clip and then wire is mainly indicated in cases that were proven to be histologically positive before neoadjuvant chemotherapy in the axilla. Histologically positive
meaning
lymph nodes in the axilla, and then they receive neoadjuvant chemotherapy. So it helps a lot to do a sentinel lymph node biopsy after neoadjuvant chemotherapy to know which lymph node was positive.
Yes, sir. Please proceed.
It helps a lot to know which lymph node in the axilla was positive before neoadjuvant to be able to retrieve it during post-neoadjuvant surgical treatment. This was introduced by Codell, and to remove this lymph node together with doing a sentinel lymph node biopsy takes the false negative rate to 1.5%.
Even if there are multiple, or are talking about one lymph node?
Actually, the guidelines in multiple positive axillary nodes is to mark only one, the biggest and most representative lymph node.
Okay, thank you, Professor Sharif. Yes, Dr. Meragbi. مايك هنا لو سمحت بسرعة بس. عشان برضو يبقى more impressive كده الناس كلها تبقى سامعة.
Dr. Sharif is my colleague and my senior professors at the NCI. I listened to this very comprehensive talk more than one time. And I think the idea of omitting axillary nodes based on the ultrasound examination is very feasible and very viable, particularly if we repeat it, make a dual to overcome the difference in personal experience. We can do dual ultrasound by two different experts or triple, and in the end of the day, you can omit the axilla management based on the ultrasound. My question to you, based on the studies that you presented, I don't understand the studies that show that you can omit the axilla if you have 3 or more. Maybe you mean 3 or less. The study that you presented and said you omit the axilla in case you have 3 or more positive sentinel. No, I think it may be 3 or less.
3 or less. Yes.
Yeah.
No? Okay. هات المايك بقى لو سمحت بعد إذن حضرتك.
This was only a practice evaluating study, and it found that it is done in about 50% of the time, only in old, frail patients who are low risk. They sometimes have 3 or more positive sentinel nodes, and they cannot withstand axillary surgery. So what you do is you depend on postoperative irradiation. And it was found that even in positive sentinel nodes, postoperative irradiation gave the same disease-free survival and overall survival as completing axillary lymph node dissection with less than 50% incidence of lymphedema when compared to axillary surgery. Nevertheless, it is not given as guidelines. This should be evaluated in each individual patient if you think that axillary dissection would be a high risk for this patient.
Thank you very much. Now for Dr. Ahmed Amin, any questions? Radiotherapy? No questions. Okay, thank you very much. I'm sure we all enjoyed this session. Good luck to all of us.